Hi, my name is Rich. I am the founder of Medical Referral Hub, and thank you all for joining us on this video today. With me is Marlene Hurd Allen, Ph.D. with over 40 years of healthcare experience, and we are blessed to have one of the best physiatrists in the Houston area, Dr. Craig DiTommaso. Good morning, Dr. DiTommaso. How are you, sir?
Good morning, Mr. Hurd. Thank you so much for having me. This is a real honor for me.
Absolutely. Glad that you can make it. So Dr. DiTommaso has 10 years of experience practicing medicine in the greater Houston area, particularly in Humble and Kingwood. And he was actually introduced to the medical field after his father had a spinal cord injury. So we were blessed with one of the great physicians out of need once he saw how his father was impacted by his spinal cord injury, which I think is absolutely an amazing story.
No, thank you for that. Yeah, I was in junior high actually when my father had a farming accident.
Okay.
Had a severe injury and had to kind of relearn how to walk and do all of his basic activities. Dealt with a lot of pain and psychological trauma as well. And it gave me a real respect for what people have to go through to recover from medical and traumatic injuries. And so it really inspired me to try and be there for others and to help them along their journey.
That's awesome. That's fantastic.
Now, TBI, traumatic brain injury, I know you're kind of big on that one, or should I say big on that? You know, I worked as a neuro nurse for some years. I worked in neurology and in neuro ICU. And I just think that's that's a part of the body that is so most challenging. So what are some of the conditions that you do treat?
Sure. So definitely traumatic brain injury is an area I think I have some expertise. And I would just ask people who are maybe watching this who are unfamiliar to remember that brain injuries come in all kinds of different flavors. We saw recently a member of Congress fell and hit his head very hard and was having some issues with concussion afterwards, headaches. That is a brain injury. That's something that needs rehabilitation and proper medical management to improve. I think on the other end of the spectrum, of course, everyone's familiar with car accidents or workers who fall and hit their heads on something. Those are severe injuries, and those people need lots and lots of rehabilitation in order to regain their not only their ability to kind of function, but to remember who they are, to get back to some of their important lifestyle and habits and so forth. And so I think that the field of brain injury, one, is a very wide and diverse field, but two, it affects people in so many different ways. As a physician, I just love working with people to help them regain both their function, that is, getting dressed, getting out of bed, walking down the hall, as well as regaining who they are, getting back to fishing or reading or whatever it is that they find personally meaningful. So for me, I think brain injury is just a great field to work in because there's so much hope and so much ability to help. Other conditions that I see commonly in the rehab field are strokes, of course. Strokes are extremely common, especially here in Texas. And just like a brain injury, they really affect both how the person functions as well as what they're able to do. And so by engaging people post-stroke in a rehabilitation program, again, you get to see them regain the ability to do those things that they might have lost, but also regain a sense of self, which is wonderful. Of course, building off of my father's injury, spinal cord injury is a very traumatic injury. It changes the way your body works and how everything evolves from the spine in some way, whether it's walking or moving or even things like urinating and defecating, pooping and peeing. And so that kind of medical rehabilitation is also very rewarding. Recently, I have to say, we've seen an awful lot of patients who have been struggling with COVID who've needed a tremendous amount of rehab as well. COVID has really manifested in a lot of different ways in the patient population. People with difficult thinking, people with difficulty moving, difficulty breathing, of course, as you might expect. And so we've been able to gear our rehab efforts at helping those people recover and get back to themselves as well.
Well, thanks for sharing that. You said something that triggered a thought when you said about the person of Congress who fell. Years ago, we had an accident downtown where a young lady was hit by but I happened to have been one of her assigned nurses, and then there was a nursing student who was a friend of hers, and she was totally shocked to see the difference in her personality. So this is something that the lay people do not realize, but for her, it was like, wait, this is a lady who was so nice and quiet and never said it. Now she was shouting, loud, boisterous. So the brain is a challenging organ. Yeah, thanks for sharing that.
Absolutely. So I have to admit it. You've got 10 years clinical experience. Marlene's got 40 years. I'm on the lower end of the spectrum, around 4 to 6 years clinical experience. So I need for you to explain to me and to the viewers the difference between physical therapy and physical medicine.
Sure. Physical therapists are really vital members of the rehab team. Their job is typically to directly interact with the patient to get up and do exercises or interventions to help them regain some activity, whether that's walking or getting out of bed or getting dressed, those types of things. The actual hands-on approach are done by physical and occupational therapists. As a rehab physician or a physical medicine and rehabilitation physician, our job is more to create the plan that's going to help the person recover, to look at all of the aspects, the brain injury or stroke, the weakness in the leg, maybe thinking problems, as Ms. Hurd mentioned earlier, all of those kind of different pieces, and then put it together in a plan that will help that person regain their sense of self. Those of you who have ever built a house, you know that there's lots of very skilled individual practitioners who come in. You have a carpenter who may build the cabinets, you have a floor guy who lays the floor. These people come in and they have tremendous skills, but there's usually a foreman or a contractor who gets all those people working together and on the same page. That's the role of the rehab physician. Our goal is to talk to the internal medicine doctors, the neurologists, whoever else is involved in the case, talk to the therapist and create a plan for this person's recovery. It's an often overlooked but really important part of the piece in order to maximize the recovery and benefit. And that's why I really love the field of rehab medicine, because I love being that manager and helping the patient put together a plan that works for them and gets them back on their feet.
Wow, that was a really cool explanation. I'm definitely gonna use that one in the future. Appreciate that.
Yeah, if you're ever building a house, just remember Dr. DiTommaso said, the contractor, he's over everything, but that's a good way to relate to the lay people. Yeah, Great one, good one. So Dr. DiTommaso, we just talked about some of with the TBI. So in some of the neurological conditions that I worked with in the past, and do you work with any of these in the physical medicine rehab? And then one of the number one ones I had was ALS, Guillain-Barré, multiple sclerosis, and then even with some of the cancers, I remember like the glioblastoma and how it just had that negative effect on the body. So do you treat any of those conditions?
Yeah, as a rehab physician, our scope is a little bit different than other doctors. You may go to a neurologist who's going to deal with almost anything that deals with the brain. From a rehab perspective, I'm much more worried about, does this person have a plan for recovery? So there may be a patient with multiple sclerosis or who has a brain tumor, as you mentioned, who already has a plan and has good family support. I may not need to play much of a role in that person's recovery. They've already got it figured out, so to speak. My interest is more in people, regardless of the diagnosis, who are not doing what they need to do, who are not back on their feet and don't have a plan. That's where I feel like rehab physicians do the best work. We can come in, talk to the person, evaluate what their resources are, their friends, their family, whatever you have, their diagnosis, and then put together a plan that works for them. So rehab's a lot less about a specific diagnosis. Any diagnosis is fine. It's much more about helping a person understand their path forward. And so those are the patients who I'm most interested in. But yes, I have seen all of those diagnoses in acute care, in LTACs and rehabs and skilled nursing facilities working on that rehab plan together. So
I was just going to say you're the coach, but now I might have to say you're the athletic director. I'm switching from being in the house now to being
the coach or the general manager. I'd say
there you go.
Okay.
Sounds good.
So I'm a very big tech guy, and in the past, working in the LTAC setting, I have wandered past the rehab gym and seen a couple of pretty awesome things. One of those things is the exoskeleton from EKSO BIONICS, and I just thought that was one of the coolest things in the world. because we had patients that couldn't move, couldn't walk, couldn't really do anything. But once they were in the EKSO, they were able to kind of remember how to do those things. Could you tell us a little bit about your experience with that machine in particular, and where you see robotics in the future as it relates to rehab?
I think that robotics are definitely the future of rehabilitation as a tool in the larger picture, so to speak. So I still believe that each individual has to be evaluated, and a specific rehab plan has to be designed around them and their strengths and their weaknesses. But as we've kind of alluded to, lots of different patients, whether it's a brain injury, a stroke, a spinal cord injury, lose that ability to walk or mobilize and get around. You can certainly work with physical therapists and other practitioners to get people up and get them moving, but it's incredibly laborious. If you could imagine yourself having a stroke or a spinal cord injury and then trying to get up and walk when your legs don't work well, when your strength isn't there, you would need 2 or 3, maybe 4 people to carry you as you're doing that. That's very difficult to do. It's possible, but it's very, very difficult. And so what we see is a lot of those people have their recovery arrested because there aren't often enough hands simply to get them up and get them moving. The EKSO Bionic is a robot that takes that need away. You can get a person up in the robot and moving from day one with only the help of one physical therapist oftentimes, so that they can begin to work on that walking, that getting back to normal, where you're not waiting for 4 or 5 people to be free to get them up and moving. So it's an incredibly powerful tool when used properly.
Oh, that's awesome. Like I said,
they didn't have that when I was in the clinical setting. That would have been a great
I was just about to say that. I was going to say the advancements that we've seen in the last 10 years even get me excited for what's going to happen in the next 10 years. It's pretty remarkable what they're coming up with in those labs. I'll tell you that much.
It is. It's really exciting time to be in the rehab space.
Yeah. So Dr. DiTommaso, I don't want to take over, but I just got to jump in here. Just listening and correction, Rich. Mm-hmm. He might be practicing for 10 years, but I promise you he has 20 years of medical experience, because you got to think about, med school, his residency. Am I right, Dr. DiTommaso?
And taking care of my father before that, to be honest. So that was a crash course in medicine and rehabilitation in a lot of ways. So
there you go.
I feel like I've been doing this my whole life, to be perfectly
honest. We're going to triple that 10, okay? We're
going
30 plus.
Okay. We'll call it 30 years now. We'll call
there
it.
There you go.
That's all. So Dr. DiTommaso, you've worked with plenty of neurological injuries, but as you said, strokes are prevalent in Texas. And how are stroke patients cared for differently at the different levels of care, particularly LTAC, acute rehab, and skilled nursing facilities?
Sure. So after someone has a stroke, typically there's kinds of 3 options of places they can go for further rehabilitation if needed. Oftentimes, if they're incredibly sick or if there are extenuating circumstances, they'll look at what's called an LTAC, or long-term acute care center. These are really centers for people who kind of need to live in the ICU. They're very good at managing very medically complex situations. So depending on the medical complexity after the stroke, one option for the next step could be an LTAC, or long-term acute care center. The next option is acute rehabilitation. And to be honest, that's where I do most of my work. An acute rehabilitation center is typically a standalone hospital or an auxiliary to an existing hospital that focuses mostly just on the rehabilitation aspect. And so when patients matriculate to a rehab center, they're expected to do 3 hours of rehab a day, to be engaged in their therapies, and to get up and get moving. I think that this is oftentimes the place where we see those kinds of big steps and big progress when patients come in with a stroke or another diagnosis for this conversation, stroke, and really get good therapy, get physiatrists or rehab doctors like myself interacting with them and making tremendous progress towards getting more independent. The third option is what's called a skilled nursing facility. Other people may call it SNF or SNF. They may also call it subacute rehab. These are places where the focus is really on nursing care. There is some rehab there, but it should not be confused with acute rehabilitation. Patients typically go to skilled nursing facility when they need a little bit more nursing care in order to kind of get back to where they need to be. The order in which someone progresses through these does not have to be linear. In other words, you don't have to go from an acute care hospital to an LTAC, to a rehab, to a skilled nursing. It can happen in almost any order depending on what's best for the patient. And again, an area where I feel as a rehab physician, I can be most helpful because I can kind of structure this in a manner that makes the most sense for the patient and their needs. But all of those levels of care exist, and it just depends on what's the right next step for the patient. Each one, of course, has pros and cons, and it has to be worked through very carefully.
Listening to you, sir, I think on the field of mentorship, and I was just thinking about looking at it now from the medical standpoint, you know, because a mentor is a mentor. But I look at it and I said, and I'm thinking of you right now, I said, that's like medical expertise, nurturing tomorrow's researchers, sharing health in progress. Because that's what I hear in you, and that's what I see in you. And even when we first met, I sense that passion. And so I wonder how with Rehab, we could get into you doing some mentorship with some of the young physicians. Like you had initial one with your dad's injury. You know, you didn't even have anybody to speak to you then. That was something that was innate. But now you have that opportunity to pass that on. So how would we go about mentorship, especially
There's obviously some bureaucratic hurdles that we need to jump, but if there is a young person out there who's interested in medicine, whether it's a physician, physical therapy, nursing, regardless of their discipline, the different rehabilitation centers and hospitals I work at have lots of programs. Just a matter of getting the paperwork filled out and getting things set up, and I'm happy to have anyone shadow me or hang out for whatever free time or availability you have. Absolutely.
So if someone wanted to reach you for those purposes, how would they do that?
Well, if they're not opposed to it, I actually think the easiest way to get a hold of me is on Twitter.
Okay.
I'm very active there. I keep in touch with a lot of colleagues, and for me, it's just a very simple and straightforward way of sharing information. So I would say the first thing, if someone is comfortable with social media, Twitter is the first way.
Thank you, Dr. DiTommaso, for joining us here at Medical Referral Hub. We absolutely loved speaking with you today, and we look forward to working with you more in the future. Please say hello to your wonderful wife, Amy, and your daughter, Isabella, and your son, Lorenzo. We greatly appreciate them supporting you while you care for the greater Houston community.
No, thank you for having me. It's a real honor.
Absolutely. Have a great day, sir.
You too.
Thanks. Bye.